وحدة أمراض الدم والأورام في اسم الأطفال جامعة عين شمس، ومدير الوحدة الحالي، مش كده يا مروة؟ مدير الوحدة الحالي. لا، ما هي مدير الوحدة النهائي، عشان كده عايزة تاخد أجازة، ما نأجلها شوية. دكتورة مروة وحيد طلبة، وهي one of the team of the infection control باسم الأطفال. هتكلمنا عن الانفيزيف فانجل انفكشنز كيس سيناريوز. اتفضلي يا دكتورة مروة. ربع ساعة، بأكد بس إنها ربع ساعة.
تمام يا دكتور. السلام عليكم. Thank you so much, Dr. Muhammad, for the introduction. Thank you, Dr. Azza, for this opportunity. Assalamu alaikum. Thank you, Dr. Muhammad, for this introduction, and thank you, Dr. Azza, for this opportunity. Today we will talk about highlights on invasive fungal disease. Our case is an ALL pre-B girl. She's a 2.5 years old female patient living in a rural area, diagnosed as ALL pre-B on November 2022, and she was diagnosed as low risk group based on her initial total leukocytic count, age, flow cytometry, and cytogenetics. Her initial rectal swabs and cultures were negative for pathogenic growth. She started her induction protocol as per total 15 protocol on November 2022. Is this patient ALL pre-B low risk, high risk for fungal infection? Actually, risks for invasive fungal disease include underlying conditions as ALL and AML, hematopoietic stem cell transplantation, solid organ transplantation, ICU patients following abdominal surgeries, acute necrotizing pancreatitis, and patients with comorbidities as premature birth, esophagitis following chemotherapy, dialysis, severe influenza, or pneumonia are other risk factors. Iatrogenic causes predisposing for fungal disease include neutrophil count less than 0.5, prolonged steroid therapy, broad-spectrum antibiotics, central venous lines, and TPN. What about the genetic and environmental factors? Do they contribute to the risk factors? Actually, environmental factors play an important role in invasive fungal disease. Colonization with candida, species, building and renovation works, smoking areas, all these contribute to the risk of invasive fungal disease. Congenital immune deficiencies, including CGD, defect in T helper 17 T cell response, and other risk genotypes described for Toll-like receptors, all these contribute to the risk factors. Not all that is enough. Disparities in access to healthcare and socioeconomic disparities are also another risk factor, so it's multifactorial. So our patient is at high risk for invasive fungal disease as well as other bacterial and opportunistic infections. Does she need protection? Actually, based on ECID guidelines 2020, that pediatric guidelines strongly recommend primary antifungal prophylaxis for all patients at high risk of developing invasive fungal disease, including the ALL patients. And the NCCN 2023 has put the ALL patients as well as the AML in the intermediate to high risk for invasive fungal disease, and they recommended coverage with antifungal prophylaxis typically until resolution of neutropenia. Which prophylactic antifungal therapy should we use? Actually, this is a little bit a problem in our low middle income countries because of the availability of safe forms of effective drugs, the cost, and the drug-to-drug interactions that actually happens with some of the chemotherapy the patients are on. So back to our patient, she's an ALL low risk 2.5 years old girl on induction protocol, and this patient was put on antibiotic and antifungal prophylaxis, and we started her with echinocandins. Fever. It's a nightmare for any patient dealing with solid oncological patients. This patient developed fever persistently, 38.5 to 39.5, associated with watery greenish diarrhea of large amount. This took place on day 13 of the induction protocol, and unfortunately her neutrophils at this time was 0.01. CRP was 106. So blood cultures were withdrawn and antibiotic escalation was done based on the hospital policy. Is this patient having now bacterial or fungal infection? We still do not know. Follow-up 72 hours following fever onset, the patient was still having high-grade fever, severe diarrhea, and started to develop soft tissue redness and ulceration in the perianal area as well as the lower back. Microbiologically, unfortunately, blood cultures were inconclusive at this time. They showed contamination, and this could be related to the bad culturing techniques. Repeated blood cultures were withdrawn every 48 to 72 hours according to the availability. Radiologically, abdominal imaging showed picture of typhlitis in antibiotics escalated on clinical basis and radiological basis. Fungal screening as per guidelines done. Chest scans were free, and paranasal sinuses showed left maxillary sinusitis, ethmoidal sinusitis, opacification that was not suggestive for fungal infection, no bony destruction, and no invasions, fungal invasion. Again, is this patient going with bacterial or fungal with the history of diarrhea, persistent fever, skin infections? We were more inclined to that she's having a bacterial infection. Persistent diarrhea continues more than 15 times per day. Fever continues, lower back ulceration, more red, and now oozing. Supportive measures were increased and fluid therapy was given. The patient had 2 days duration of unilateral left periorbital edema. This edema was not associated with redness, and there was no tenderness associated. The patient at this time was hypoalbuminemic with many fluid intake because of the persistent diarrhea that she was having. Could this edema be related to fluid overload, as the patient was persistently sleeping on her left side because of the pain caused by the ulcers in her back? However, CT orbit was requested to exclude any cellulitis in the area. At last, blood culture result was significant, and it showed Klebsiella MDR resistant to meropenem and aminoglycosides. Cultures taken from the ulcers and the perianal lesion as well showed the same organism. So antibiotic tailoring to cover the MDR was done, and patient was started GCSF as well for fear of losing the patient, and this was by the help of my dear friend Nihal. She insisted on adding the GCSF. Fever started to improve after changing the antibiotics. So now we identified the organism, we tailored the antibiotics upon, and the fever started to improve. So what about the periorbital edema? It was clinically resolving. No tenderness or redness at the sinuses or periorbital area. The CT orbit that was done at that time showed left subcutaneous tissue edema, as well as rarefaction of the left medial walls of the ethmoidal sinuses, as well as haziness of extracorneal fat of left orbit, raising the possibility of extension of infection to the left orbit. Picture suggestive of preseptal cellulitis and complicated sinusitis as described. Again, could this preseptal cellulitis be fungal or bacterial? The picture of bony rarefaction raises the idea of fungal. However, the patient was clinically improving on changing on the antibiotics, and radiologically, the radiologists could not differentiate between fungal and bacterial, and they requested MRI orbit. ENT examination was requested, and they said it's just for follow-up, not suggestive of fungal infection. So patient was then put on voriconazole for widened fungal coverage until doing the MRI. So again, a resume for the patient. She's a 2.5 years old, ALL, pre-B, low risk, was put on prophylactic antibiotics and antifungals as per guidelines, developed fever day 13 when she was severely neutropenic, sites of infection, intra-abdominal, soft tissue, and sinusitis, microbiologically proven Klebsiella MDR, clinically improving on targeted antibiotics. So we did a great job. Fever returned again. This was on day 30 induction. Low-grade fever, 38, 38.5, once, twice per day, and the patient was clinically well except for the widening of the nasal bridge and recurrence of the left unilateral periorbital edema. Are we having now resistant fungal infection? So we modified the medication to broaden the spectrum of the antifungal coverage. We put her on liposomal amphotericin B on 5 milligram per kg per day to include mucormycosis in our coverage, and we urged the ENT to go for endoscopic examination and debridement. And actually, this was the picture of the endoscope showing grayish soft tissue lesion inside the sinuses, and it was reaching the lamina papracia the septum between the eye and the orbit, and this was done by Dr. Michael Inawi, lecturer of ENT in our Ain Shams University. So the endoscopic picture at that time was suggestive of mucormycosis. And the pathology as well showed multiple soft grayish tissue pieces, devitalized tissues with non-septated, non-branching fungal hyphae surrounded by neutrophils, lymphocytes, and histocytes, picture suggestive of invasive fungal infection mucor. And this is to differentiate between the aspergillus and mucor. Mucor is mostly broad hyphae, rare or no septations, and branching, if branching, it's irregular and at 90 degrees, while the aspergillus, they are narrower and they are with regular branching and regular septations. But we were on prophylactic antifungals, so why this patient developed fungal infection. Actually, this is the breakthrough invasive fungal infection that was defined by this ECMM as infection occurring during exposure to an antifungal drug, including fungi outside the spectrum of the activity of the antifungal. What adds to the difficulty of the diagnosis is that galactomannan is negatively influenced in patients receiving more active prophylaxis or treatment, and thus diagnosis is challenging and needs pathology or cultured diagnosis. Antifungal prophylaxis influence on a breakthrough invasive fungal infection. The use of prophylactic antifungal agents resulted in change in the epidemiology of invasive fungal infection in this highly susceptible group. Antifungal resistance, which typically follows antifungal exposure, can select out a breakthrough pathogen resistant to the agent prescribed. Thus, mucormycosis and infections caused by other rare molds, such as Fusarium, are now more commonly seen in patients receiving voriconazole or an echinocandine. Actually, rare molds are more seen in breakthrough invasive fungal infection than non-breakthrough invasive fungal infections. So we need to study our epidemiology and tailor our prophylaxis and treatment to suit our environment. Risk factors for breakthrough invasive fungal infections are many, including iatrogenic as inappropriate antifungal therapy, fungal biofilm on indwelling catheters, host-related factors including our patient as leukemia, mucositis, immune suppression including glucocorticoids, and the patient was on them, broad-spectrum antibiotics that the patient was also receiving, and CVC and genetic factors. Back to our GERD. Chemotherapy interrupted till controlling infection. Patient required another 2 sinus debridements and was followed with ENT department Professor Ayman al-Kahki and Dr. Michael Linawi. And she fortunately just ended her reinduction too on 21/9/2023 and doing fine. So fungal infection is deceiving, life-threatening, and costly. Diagnosis cost is far less than empirically treating blindly. Diagnosis is crucial, and every attempt for diagnosis should be done. Exact identification of fungal type and antifungal sensitivity is mandatory. Multidisciplinary team with early surgical intervention is mandatory whenever possible. Reversing any risk factors is a must till condition improves and infection is controlled. And since the presentation was about infection, we have to mention the antimicrobial resistance that we are suffering from in Egypt. And actually the iceberg starts from below, not from the up. It starts in the community and the primary healthcare centers with the animal health and food production industries that have overused and abused antibiotics, resulting in increased risk and increased incidence of MDRs in our hospitals and the ICU. So we have to readjust the usage of our antibiotics in our community. And this is our lovely unit, and thank you so much for your attention. Thank you so much.